Morning. Uh, so it's a wonderful hall, and hope we will fill it up by the time we start. So I think all the participants, the finalists are already here. So we need expect 16 students, the bright students, the teachers of tomorrow to be here, and they must have picked up your lots. So I welcome Dr. Saptagirish from the Shankara Group, Bangalore, and also Dr. Naina Podar, Mumbai, who are our gracious judges, who will be actually having the arduous task of deciding who are the best teachers of tomorrow and who is going to replace us in the conferences to come. And I'll tell you, I'm just warning you that this is going to be a very tough task. They are extremely good. They're actually going to give us a run for money. And we have the 16 topics already given up to you now. The rules remain the same. The judge's decision is final. They're going to actually show us, it's a very transparent system. They're going to show us the marks right away so that you can know where you stand. And it's the combination of the summation of the marks of both the candidates that makes a team to be the judge that's the best. And we have the first, second, third, the gold medal, the silver and the bronze medals for the participants, also the mentor. And the rules, 4 minutes and 10 marks, 4 marks for the content, 4 marks for the presentation skills, 1 for finishing before time, and 1 for the one question that will be allowed by the judges to be answered. And so if everything is fine, let's get started. Uh, Dr. Nilima, the sequence is ready? Okay. So it's like one candidate as per the sequence will present, then the second sequence starts from the second candidate in the same order. क्या इनका है सो जजेस को नीचे ही बिठाना है ऊपर बिठाना है किसको जजेस को इधर बिठा देंगे जजेस को हाँ So I call upon Dr. Saptagirish, Dr. Naina to please come out to the dais and take your seat. Uh, so may I call the first team, the Maurya's Master Blasters, mentored by Dr. Arvind Kumar Maurya, and Dr. Ashwita will be, welcome sir, welcome ma'am, all the best. And you have the I know what most. Now nobody like Prabhu. So we have the first candidate, Dr. Ashwita. You're the one? Okay. So all the best, Tots. Hope may the best win team, but all of you are here to reach this hall, this stage of this particular conference, this competition itself is a great achievement. So please carry that, keep the flag, high, flying high.
ऑन है क्या ऑन है स्लाइड चेंज
So the first team is Moria's Master Blasters. Are we ready?
यस सर
The mentor is Dr. Arvind Maurya and you are?
डॉक्टर अश्विता सर
Okay. You can start.
शैल आई स्टैंड देयर
Okay, so we have team Moria's Masters Blasters. Mentor is Professor Arvind Maurya, and Dr. Aswita and Subhav are representing the team. So Aswita, you can start.
A very good morning, class. I hope all of you are not like droopy lids like this. We watched cartoon, right? What do we associate all these characters as? Sleepy? It's not moving, sir. Excuse me, it's not moving.
Sleepy.
Sleepy, sarcastic, or snide. Funny how droopy lids also give a cartoon a character. Speaking about character, Manthara, the iconic character of Ramayana played by Lalita Pawar, we know she definitely used her ptosis to advantage. And what about Forrest Whitaker saying Wakanda forever? So let's dive into how to approach a case of acquired ptosis in real life. The most important is the history. What is the mode of onset? Is it sudden in case of a neurogenic ptosis, or is it gradual like an aponeurotic or a myogenic ptosis? What is the variation? A diurnal variation is more suggestive of a myasthenia gravis. And what about the history of family history of ptosis, any trauma, thyroid, malignancies, surgeries? The previous photographs gives us a clear detail of what is the progression of the ptosis. After taking a detailed history, we go on to examine the visual acuity. The inspection is done to see if it is unilateral or bilateral. What is the facial symmetry of the patient? Does he have a frontalis overaction? And next we go on to a basic ptosis evaluation, which is done in a well-lit room with the pupils being in the primary gaze. The palpebral fissure height is the vertical distance from the upper lid to the lower lid margin in the three gazes. The marginal reflex distance is the key to really diagnose ptosis, as it helps to diagnose mild, moderate and severe ptosis. The margin crease distance is the first prominent sign when you see from the down to the up gaze. The levator function is assessed as the maximum excursion from the down gaze to the up gaze when the frontalis is blocked. Grading this becomes extremely important while you're planning for the surgical correction. Bell's phenomena, the out and upward movement of the eyes while forceful closure of the lids. So this was the basic evaluation. What about if a patient comes with progressive diurnal variation and limited ocular mortality? What are the special tests you would do? Dr. Krishna Prasad, you being my favorite student, do you have anything else you want to do for this? It's okay, let me take you through this. Fatigue test, where the patient looks down and up about 10 times to see if there is any difference in the ptosis. The Coggin slit twitch test, where there is a twitch after a break when the patient looks down. Or the ice pack test, where the patient is placed ice pack to see if there is any difference in ptosis after 2 mm. A positive result in all of them is suggestive of a myogenic ptosis. How about a case with progressive, moderate ptosis but good LPS function? Here we see she has a higher lid crease and the droop increases on down gaze. This is suggestive of an aponeurotic ptosis. Well, a funny comparison where there is an increase in stretching of the tarsal plate but no disinsertion suggestive of a dehiscence, or the fatty infiltration of the LPS suggestive of a degeneration, or a complete disinsertion from the tarsal plate suggestive of a dehiscence. So there are other types of ptosis like mechanical and traumatic, and each ptosis requires a proper evaluation in order to provide a tailor-made approach and to provide a cosmetic and functional outcome. So the next time the patient comes to you with ptosis, let them know. Don't let that ptosis bring you down. Thank you.
Thank you, Aswita. In the meanwhile, the other speaker may please start from this side to save time. Yes, judges can ask the question now.
Yeah, nice present, Asmita.
Thank you.
Yeah, I like the way you made an extempore and try to involve the audience. It's very important for a teacher to involve the class actively in the presentation rather than making it just read out the text. Wonderful way of presenting, and actually the modern way of teaching is that way. And just, yeah, a couple of points which you missed out, but I think overall it's very nice.
Thank you, sir.
Question from
Question. My question is, how will you? I am your student. How will you teach me to differentiate between ptosis and pseudotosis?
Great. We have a very obedient and very eager student who wants to know what if a pseudotosis comes to us. So what do? You cover the normal lid, bringing the other eye to the normal position, and then we evaluate the ptosis. So you might be wondering what causes pseudotosis. Do you have any opinion about that? Any lid retraction, in ophthalmos, these are the other causes. So you cover the normal eye, and then once the position of the eyeball comes into primary position, we assess the ptosis.
You mean fixation, doctor?
Yes, fixation.
Okay, thank you.
Thank you.
You can start. Dr. Subhav.
It's not audible. I'm audible?
Yes, yes, you are audible.
Can I have my slides, please?
Suppose you should display the marks now to them. Okay. I know. So we display her marks now.
Subhav, I think there is a change in plan.
Okay.
So you will have to wait for your turn.
All right, sir.
Now the second team will come. Dr. Anu, could you please invite the second team as per your list?
So we have to display the marks, Pradeep.
Can we have the next teacher of tomorrow, Dr. Hiba Abdul from the team God's Own Warriors? Okay, Archana Kumar on newer advances in management of myopia.
Dr. Anu, could you please tell us the third team so that their speaker is ready on that side? That way we can save a lot of time. Ask the third team to be ready on that side, that podium.
Check.
Can we have the presenter from the third team towards tomorrow at the other podium?
Yes, Dr. Archana.
Good morning, class. So for today, I'm just going to tell you a small story for 4 minutes, and then you can have the rest of the class off, all right? So let me introduce you to the protagonist of today's story, Master Kiran Chatterjee, who is an 8-year-old male. So Kiran, as you can see, is like most of you these days. He loves his phone, his iPad, his Game Boy. Eventually, he starts having trouble seeing the blackboard, and so his parents are worried and take him to a doctor. The doctor diagnoses him to have myopia. So class, the topic for today's discussion is advancements in the management of myopia, the non-surgical options. All right, so let us begin. Let us start with the first modality of treatment. Can anyone take a guess at what it could be? Yes, it is outdoor activity. But how could outdoor activity help? There are various theories and mechanisms proposed as to why outdoor activity helps. One is that there is an augmented exposure to bright light, there is higher vitamin D levels, a reduction in the accommodative demand and accommodative lag, and decreased nerve work. But of course, Kiran is like most of you these days. He hates playing outside and he misses his phone and iPad way too much. So he goes back to his old ways. His myopia progresses further. His parents are worried and ask the doctor for another modality of treatment, which brings us to defocus incorporated multiple segment lenses. Now, how do these lenses work? These lenses work on the principle of myopic defocus. So, in an uncorrected myope, the central rays of light are focused on the retina, while at the periphery or behind the retina. Normal single vision correction brings the central rays onto the retina, while at the periphery are still behind the retina, causing a hyperopic defocus. These DIMS lenses bring the peripheral rays in front of the retina, causing a myopic defocus. So the hyperopic defocus acts as signal for the axial elongation, and the myopic defocus curbs this signal. DIMS lenses have a central 9 mm zone for the myopic correction and peripheral zone of plus 3.5 diopters to induce this myopic defocus in the eye. Alright? But of course, despite all the various shades, sizes, colors of the frames, Kiran was just not interested in wearing his glasses. So the parents asked the doctor for another modality of treatment, which brings us to ortho-K lenses. So how do ortho-K lenses work? They have a central curve and two steep curves with both which a combination of negative and positive pressure effects alter and flatten out the shape of the cornea, thus affecting the diffraction of the eye. But the problem with these lenses, of course, as anyone could guess from this picture, are that they have to be worn overnight and could be quite cumbersome. So then the doctors asked for another modality of treatment. The parents asked the doctor for another modality of treatment, which is dual multifocus soft contact lenses. So these work on the same principle as the DIMS lenses, which was, yes, myopic defocus. Alright, so the central zone is of myopic correction, and there are alternating zones of plus power to induce the myopic defocus in the eye. So the parents asked the doctor if there's any sort of topical medication that could also help this child. So they recommended the doctors recommended the use of atropine, that is 0.05% atropine at night. So let us recapitulate. There are various mechanisms as to how atropine works. A combination of muscarinic and non-muscarinic effects help in curbing the axial elongation of the eyeball. So let us recapitulate. What are the methods we learned? Outdoor activity, the DIMS lenses, ortho-K lenses, dual multifocal lenses, and low-dose atropine. You can take a picture as a reference for future purposes. QR code for more references. Thank you.
Thank you, teacher. That was an excellent class, I would say. Question from the juries?
Very crisp presentation, I should say.
Thank you, ma'am.
Liked all the pics and everything detailing. Is there any contraindication, madam, for not putting atropine drops?
So ma'am, initially atropine, they had studied 1% atropine, and that had a lot of side effects, like muscarinic side effects. But this with 0.01 atropine, they have found very minimal side effects. So
Like what?
there's like photophobia and yeah.
I'm asking about contraindication.
All right.
Any contraindication?
Which kids you would not like to put?
In any children who have congenital myopia or pathological myopia, basically atropine helps in curbing the axial elongation. So other causes of myopia, it'll be contraindicated, like congenital or pathological myopia.
Can I have the next presenter from the team Towards Tomorrow? Narendra Rajak, he'll be speaking on optic disc changes in glaucoma.
Good morning, class. Hope everybody is not sleepy and had a good cup of tea in the morning. So, come on, response. Yeah, thank you. So, can you guess what am I going to teach today with this cup and a disc? Any guesses? Yes, you are correct. Optic disc changes and evaluation in a glaucoma. Change in the appearance of optic disc can be the first finding in a patient of glaucoma. Fundus examination is of utmost importance, so 5 hours have to be examined in the optic disc examination. First is the scleral ring. Second, neuroretinal rim evaluation, retinal and optic disc hemorrhages, retinal and nerve fiber layer, and region of peripapillary atrophy. Coming to the first star, that is the scleral ring. Disc sizes can be variable. 1.4 to 2 mm is an average disc size. Less than 1.3 mm is a small disc size, and greater than 2 mm is a large disc size. Vertical cup disc diameter ratio documentation required to estimate proportion of disc occupied by the cup. The next two lines are very important. I mind you, concentrate here. High CDR can be normal in large disc and low CDR may be glaucomatous in small disc. I know it's confusing, but you have to understand this to diagnose a patient of glaucoma. CDR of 0.7 viewed with suspicion, and if asymmetry by more than 0.2, it is possibly glaucomatous. This size is estimated during slit lamp examination by adjusting height of the slit beam corresponding to the margins. These are some of the images which I took during the 90-day examination of my patient in the OPD. Magnification factors are multiplied accordingly. 90D, I used a magnification factor of 1.3. The second R, the neuroretinal rim evaluation. Area of the optic disc occupied by the axons is called neuroretinal rim. Normally, I greater than S greater than N greater than T. That is, inferior rim is thickest. Glaucoma damage may be diffuse, focal, or in combination. The focal loss of NRR is known as notch. An inferior or superior rim equal or thinner than the temporal rim suggests glaucoma. The third R, that is known as the Drance hemorrhages. These are the flame-shaped hemorrhages which are located in the superior temporal and the inferior temporal of the rim. These are most common in the normotensive glaucoma, and these are transient and last up to 2 to 4 months. But this can also be present in the patients of PVD, trauma, hypertension, and the patients who are undergoing anticoagulant medications. Coming to the fourth R, that is the retinal nerve fiber layer defect. Those are best examined using red-free green light. In affected areas, normal silvery striations are lost and they appear darker and deeper red in these areas. Wedge defects extending up to the disc margin are typical of glaucoma. Coming to the fifth R, that is the region of peripapillary atrophy. They have two zones, alpha and the beta zone. Alpha are the peripheral and the physiologic zones, and the inner beta zone, these are the loss of RPE and choriocapillaries and are suggestive of glaucoma. Coming to the other findings, those are acquired pit of optic nerve, bayoneting of blood vessels, those are the kinking of the blood vessels, barring of the blood vessels, and the bridging of the blood vessels, nasalization, and the lamina dot sign. The DDLS scoring was introduced to incorporate the effect of disc size and focal rim width into a clinical grading scale. The system is based on the narrowest neuroretinal rim within any position of if no rim is present. The circumferential extent of the absence of the rim is taken into consideration. This is the DDLS scoring. So points to be remembered. Disc evaluation is a challenging part in glaucoma and the diagnosis requires utmost practice. These findings should correlate to the HFA finding. If pallor is more, the area of cupping that causes other than glaucoma to be thought. Thank you.
Thank you, Narendra sir, for the excellent presentation.
It's my pleasure.
Lovely big scene.
Sir, which equipment to use to see the fundus? You said all these findings.
Yeah.
So what instrument should I use?
Like for glaucoma evaluation, for me the best instrument would be 90D lens with on the slit lamp.
Is it possible to see all these flames, hemorrhages, RNFL loss with 90D? What about using direct ophthalmoscope? I have only direct ophthalmoscope.
So direct ophthalmoscope, with the advent of COVID actually, I prefer indirect ophthalmoscope because as the COVID.
I am your student, so don't refer to me as sir.
No, actually as the COVID has arrived, so we have shifted to indirect ophthalmoscope because we prefer not going close to the patient, because I really don't want to contaminate myself with any of the droplet infections of the patients coming to me.
Thank you, sir.
Thank you.
Presentation. Another advantage of using indirect is probably that you have binocularity, so you can see your cup much more beautifully there. Nice presentation.
Thank you, sir.
Surya D from the team Diamond Dazzlers.
Team 5 in sequence, please may be ready there. Then we'll be able to save a lot of time. Yeah,
Hello?
you please start.
Hello? 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 Good morning, students. As you are going to become famous ophthalmologists in the future, let's start today's class by giving you a hypothetical patient. Oh my God, isn't she an actress? Do you know what is her complaint? She complains of excessive eye blinking, especially when she is anxious, facing the camera and facing bright lights. She also feels that her symptoms are decreased when she is sleeping, singing or concentrating on a task. So, what is the diagnosis? Yes, benign essential blepharospasm. It is a form of focal dystonia leading to episodic closure of the eyelids and is not associated with any other disease or syndrome. The exact etiology is unknown but is thought to be due to a dysfunction in the basal ganglia leading to cholinergic hyperactivity, decreased GABA function and dopaminergic function inhibition leading to muscle overexcitation. As shown here, certain factors can aggravate the symptoms and certain factors relieve the symptoms. Based on this, we can give supportive measures to the patients like artificial tears, eyelid scrubs, dark sunglasses, etc. Now, imagine your actress shooting an emotional scene wearing sunglasses. Not practical, right? But don't worry. We have a savior, the treatment of choice, botulinum toxin. It inhibits acetylcholine release by binding to the presynaptic ACH receptor, thereby inhibiting muscle overactivity. It is given pretarsally into the medial and lateral aspects of the orbicularis muscle. Now, if the patient does not respond to Botox, we can provide surgical myectomy that involves excision of the orbicularis from the upper eyelid. Patients with apraxia of eyelid opening will require a frontalis suspension. In a previous study, it was found that the photophobia in this disease is caused by a sympathetically maintained pain. So, giving a superior cervical ganglion block caused denervation of the orbital sympathetics, hence providing symptom relief. Now, suppose your patient says, I don't want any surgery or injection, I just want some pills. Then you can offer pharmacotherapy. But is it FDA approved? No, it is just a shotgun approach based on the pathophysiology that we have discussed earlier. Lorazepam, clonazepam and trihexyphenidyl show maximum favorable response. In a recent study, it was found that the Botox injection combined with repetitive transcranial magnetic stimulation improved the effect of Botox. These pulsed magnetic fields directly stimulate the basal ganglia, improving the excitability of dopaminergic neurons. However, 90% of our patients improve symptomatically with Botox, although repeated injections are necessary. So, reassurance of the patient is of utmost importance. Now, do you want to know what happened to our actress? She also responded well to Botox and she is coming routinely for her shoots and shots. That's why she is now in LA winning her Oscar. Before concluding, this is the homepage of Benign Essential Blepharospasm Research Foundation, the only organization dedicated to finding the cause and cure for blepharospasm. If you are interested, you can go to their site by scanning this QR code and click on that link to get various videos and presentations on the topic for your further knowledge. Thank you.
Thank you,
Ma'am, you
Dr.
said FDA approval. What is that? What does that mean, ma'am?
It is that the treatment is not FDA approved because it is we do not know a real cause for the benign essential blepharospasm. So it is basically a shotgun approach. We are looking at the pathophysiology, like dopaminergic inhibition is there, cholinergic hyperactivity is there, there is decreased GABA function. So to counteract that, for example, for dopaminergic For cholinergic hyperactivity, we will give anticholinergics like
Ma'am,
trihexyphenidyl.
what is FDA?
FDA approval is required for
What
Long
is
form,
FDA?
long of TA.
As
Food
a
and-
student, I don't know what is FDA.
Food and Drug Association,
What drug association?
Federation of Drug.
You had shown all the ladies in your last pic. Is it common only in ladies, madam?
It is 2 or 3 times more common in ladies than in gents.
Nice presentation, madam. Just one thing, we read somewhere that yoga actually helps sometime in blepharospasms. So I read about a university which is dedicated for yoga in India. It's located in Bangalore actually, and they do treat patients who have blepharospasm, and they join it along with Botox. And the way you showed, they give that radiation there, the magnetic radiations, and they have some yogic procedures,
Yes.
and they're showing little great wonders. So
Yes. AA also says that acupuncture, etc., can also
they've
help.
all
in
tried that, but our own country, we are doing something here, it seems apparently, and they're coming out with a publication in Nature Journal actually regarding that. So I mean, it's just something that I read about. I thought I'd share it with you.
Thank you. So who's next, Dr. Anu?
Surya.
Can we have the next presenter from team VMMC? Dr. Hitisha Mittal, she'll be presenting on pars planitis.
Abdul. Nilima, sit here.
Good morning, class. Awake? Hi, I'm Dr. Hitisha, and I'll be walking you through pars planitis very briefly. What will we learn today in this class? We're going to quickly refresh our sun classification memory. We're going to define pars planitis. We're going to see how to investigate and how to treat. Just like our earth revolves around its sun, we uveitis treating people also have our own sun, which is the standardization of uveitis nomenclature. It anatomically divides uveitis into anterior, intermediate, posterior, and pan-uveitis. Not only does it divide it, it also grades the inflammation. Don't be scared by this table. By the end of your 3-year residency, you're going to slowly and slowly learn it. I'm just going to hide it now. The examiner is going to ask you, how do we grade this inflammation? Think, any idea? We make a 1 × 1 mm slit on your slit lamp, and under high magnification and dark room, we grade the inflammation. Now we know intermediate uveitis is predominant vitreous inflammation in the absence of retinitis and choroiditis. Sun 2 classification in 2021 further categorized it as pars planitis and a non-pars planitis type. We are going to focus on the pars planitis type. So pars planitis is characterized by snowbanking and snowballs. It has peripheral retinal vasculitis, but normal retinal vessels at the posterior pole and mid-peripheral retina. And remember, there is no associated systemic disease. It's an idiopathic intermediate uveitis. It was referred to by various names like peripheral uveitis in older times, but you just remember pars planitis. So you should ask me, ma'am, how does it look like clinically? This is how a snowball, snowbanking, and peripheral retinal vasculitis look like clinically on your indirect examination. Remember, for snowbanking, use your scleral indenter and indent and see the peripheries. Now, is there a diagnostic criteria? One might think, yes, Sun 2 made our life easy here as well. It says that there should be evidence of intermediate uveitis like we just discussed. There should be evidence of pars planitis like we discussed. And also, you need to exclude the causes of other intermediate uveitis like syphilis, sarcoidosis, multiple sclerosis, and Lyme disease. Now, don't you think we missed something in this exclusion criteria for your Indian population? This is your hint. Yes, ocular TB is the most common cause of intermediate uveitis in India, and you need to rule it out. So what do you need to rule out before you rule in your pars planitis? Divide and conquer. Divide it into infectious and non-infectious. As we discussed, your preliminary systemic investigations would be dictated by your common causes. Wait, why did I put random blood sugar here? A patient of endogenous endophthalmitis can also present with vitritis, and you're not to forget this important cause. Similarly, in an elderly patient, primary vitreoretinal lymphoma can present as an isolated vitritis. So what are the red flags during examination? If there's a hypopion, think of end off. If there is bilateral vitritis, look carefully. Are you missing a panuveitis? Is there history of TB? Is there pain on extraocular movements? Or is it an elderly patient like we discussed? Detailed examination of both eyes is very important in establishing a diagnosis. A color fundus photography and ultrasound helps in investigating these patients. OCT and usage of wide field angiography further helps us in finding if there's a CME, ERM or peripheral NVEs. What is this? This is a UBM showing a cyclitic membrane. Now, how do we manage? If it's a bilateral disease, start oral. But if it's a unilateral pars planitis, you divide on the basis of severity. If it's low grade, you start with local steroids, but a high grade needs oral steroids. If there is no response, you add immunosuppressants and anti-TNF agents. What if there is still no response? That's where your PPV comes to rescue. You can use peripheral cryo and laser as an adjunct. So pars planitis is a diagnosis of exclusion. A thorough examination of both eyes is required and educate your patient about their disease. Thank you.
Thank you. So, what are the most common presentation of pars planitis in children's?
It's a clinical presentation. They
clinical.
present with floaters.
Floaters.
They will have vitritis, sir.
In young childs, 8-9-year-old, what would be the most common presentation? Usually they present with complications like cataract.
Oh, they come with complications like cataract, or they can have a BSK if it's a.
Floaters is not that common in pars planitis.
Okay.
Any absolute indication for Ozurdex in such cases, madam?
Absolute indication, ma'am.
Would primarily want to put intravitreal Ocusert.
Ma'am, a severe unilateral vitritis we would put, but actually there's always a risk of activation of viral in these patients. So actually, primary Ozurdex is not commonly practiced.
Anything you would like to look for before putting Ozurdex?
Ma'am, we have to look for infectious causes. Is there associated retinitis? Is there hypopion? Is there signs of inflammation? Or if the patient is a diabetic, he could have endogenous end-off. So we need to rule out a source.
One particular thing which you would like to do in the OPD? You have to monitor it.
Ma'am, IOP.
Can we have the next speaker from PJ Medical College,
you,
Ahmedabad?
Thank you. Thank you, ma'am.
Omkar Narayan.
Dr.
BJ
Ken-
Med, yes ma'am,
Omkar.
BJ Medical Ahmedabad.
The Bollywood teacher.
Something different. Sir, can I start?
Yes, Omkar, yeah, we got
Okay.
your name here, yes.
Yes. All right. Good morning, everyone. I am going to discuss recent advances in management of choroidal neovascular membrane. Today is a Sunday. It's morning. I know everybody is tired. One of the most important things when I am taking up this topic is I'm expecting that everyone has a basic idea of what is currently going on. I'll brush up upon it. Last time we had done a theme on Bollywood, but which is the latest advance? IPL and cricket. So please keep your minds open and I'll give some examples of cricket. Please stay tuned. Slide change.
Technical team, please. Okay.
In the pathology, until and unless you know the Ranji Trophy, you are not able to understand what exactly happens in the IPL. I'll say only three things: alteration of RP Brooks membrane, choriocapillaries running here and there, and imbalance between angiogenic and anti-angiogenic factors. What are the main players? Irrespective of the format, the main players will remain the same. Why am I saying this? Because they are important when we have to learn about the trials and the new expanding therapies, VEGF, fibrosis growth factor, etc. Now, bevacizumab, ranibizumab, aflibercept, these are all big kings in this field, similar like the picture shown above. And these are being currently used. However, what are the current regimens? Observe and plan, PRN, treat and extend, and fixed regimen. The pro-renata means typical like an Indian middle class household. You are on a Sunday, you are having your breakfast, and uninvited guests come over. You give an individualized therapy to them. Same thing happens right now. Now, why exactly do we need new therapy? A, it can give better penetration. B, it should have a longer duration of action. And C, it may be to improve existing drugs. So, coming to them, brolucizumab inhibits all forms of VEGF-A, similar like Jasprit Bumrah, who plays all three formats, Hawk and Harrier trials. Faricimab, two trials, Tena and Lucene, inhibits angiopoietin 2 and VEGF-A, and it is maintaining vision. Remember this player, he is maintaining his performance since 2 years. Surgery, we're all surgeons, but RP choroid patch graft, it was reported, it is slowly coming back into prominence. What exactly is radiotherapy? Choroidal neovascular membrane is basically a new tissue. So we are targeting by direct cytotoxicity of the new membrane. What is Eylea HD? It is an 8 mg injection of aflibercept. In pulsar and photon trials, what was shown that it showed improved efficacy as compared to repetitive 2 mg injection. Again, typical paisa vasool attitude that with less injection you give more treatment. What are biosimilars? It is an attempt to replicate the therapeutic endpoint. Please look at the images given below. Virat Kohli and Shubman Gill. We are expecting Shubman Gill to win his matches. That's the therapeutic endpoint, no matter how he wins them. So that is the role of biosimilars. Only Razumab has been approved. The others are in the pipeline. What exactly can we do more? A better site of delivery, vitreous reservoir, capsule, or a delivery boy? Should we call Swiggy, Zomato? Let's look in the next slide. According to Neurotech, it is just a simple capsule. It will release PDGF and anti-VEGF. What is a micropump? It releases medication from a refillable reservoir back into the eye. What is port delivery systems? Continuous delivery of ranibizumab. And ultimately, adeno-associated viral vector gene transduction. We put a vehicle and make sure that the drug reaches the target site. These are the references, these are articles, and also thank you to BCCI for creating IPL. Thank you so much.
Thank you.
Thank you, Omkar. Is there any role of PDT in CNVM?
Sir, PDT was studied, photodynamic therapy. In 2000 and 2003, the APT trials and VIP trials showed good improvement in classic subfoveal lesions, ma'am.
So there are no recent advances regarding that?
Sir, no, sir. That was in 2001 and 2003. We are looking through it, but these are the main drugs which are.
Any alternative to bevacizumab, which is in trial?
Any alternative? Sorry, sir.
Bevacizumab. See, bevacizumab is not approved for UJ.
Yes, sir. Off-label.
Are there any alternative that is undergoing FDA trial, which is similar to bevacizumab?
Sir, I'll have to read and get back to you, sir.
Okay, we'll discuss in next class.
We'll discuss in next class, sir. It was actually a
Tongue
homework.
twisters.
Yes, ma'am.
All the names are so tongue twisters. Difficult to remember.
Ma'am,
How
that's
do
why
we
cricket, ma'am.
remember?
IPL is going to come. That's why this analogy was used, ma'am.
Also, conversept, I hope you covered that.
Sorry, sir.
Conversept, which is 30 times potent than ranibizumab.
Sir, it is still in trial phase, but
And
I'll.
it has been approved.
Sir, this is the.
It's from China, so that has been approved based on Chinese studies. FDA hasn't done any trial of that. Anyway, nice presentation.
Okay. Thank you, sir. Thank you, everyone.
Thank you.
Soumya, you're from which team?
Can we have the next presenter from AIMS Nagpur, Dr. Meghna? She will be presenting on tests for binocularity.
Please start.
Good morning, students. I am here to reduce your stress of screen. Now we have to know just 3 questions, the what, the why, and the hows about the binocularity. Why we have to see with both eyes? Cello, every one of you close one of your eye. And just see this picture, which appears nearer to you. Yes, these are the monocular clues provided. And in this picture, can you appreciate teacup, which is clear? Yes, this is the monocular clue. And in the last picture, can you see there is less crowding when the picture is near? Yes, these are the different monocular clues provided. Then why do we require binocular vision? To expand the field of vision and for better stereopsis. What happens if there is no binocularity? There will be confusion or diplopia. Oh, these terms are so confusing. Let me explain to you. Confusion. If there are two dissimilar images forming or image on respective fovea, then it leads to confusion. This principle is used in haploscopic principle, and the test used is synaptophore test. And in diplopia, there will be single image, single object which forms two images, one on fovea and one more on parafoveal region. These are the tests using diploscopic projection. Chalo, one more time we will engage in activity. Every one of you, you have to look at one target, look at that logo and double press your eye. Can you see there is distortion and there is diplopia? Come, now let's learn the test, Worth-Ford dot test, in which patient uses red-green color glasses. Let me give you a tip. Red is used in front of right eye and the patient is asked to see 4 dots. One is green, one is red, 2 green and 1 is white. If the patient is able to see 2 red dots, then it indicates suppression of left eye. If he can see 3 green dots, that indicates there is suppression of right eye. And if he can see 5 dots, that indicates there is diplopia. And if he sees red on right side, there is isotopia. If the red is crossed, that indicates exotropia. And in Bagolini striated glasses, the striations are along these axes, and the image formed and the lines seen are in perpendicular axis. If the patient has binocular single vision, then he can see the cross. If one eye is suppressed, there will be only one line. If there is any scotomas, there will be missing lines. And if the patient has diplopia, then these lines appear to be crossing, but they don't cross. And similarly in Maddox-Rod test, they are parallel cylinders. Let every one of you tell me, if they are oriented horizontally, how will they appear? Yes, in what test we will use? Yes, it is used in horizontal foreas, and if the cylinders are oriented vertically, these are used in vertical foreas. And in 4 diopter base out prism test, if the patient has no squint, then there is outward deviation of left eye with refixation of left eye. And if the patient is having foveal suppression, then there is no deviation of right eye. Synaptophore, on which there are different binocular single vision grades are graded. This is big topic itself. We will discuss about this in next class. And tests for stereo acuity, qualitative tests are 2 pencil tests, and the quantitative tests are which are done with glasses are Titmus, TNO, random dot, Frisbee and Lance are done without any glasses. Now let's test how much you have learned. Grades of binocular single vision are, yes, all of the above. Test for stereopsis, yes. Now I have made your concepts clear, I think so. Thank you.
Good presentation, Meghna. It's a difficult topic, confusing topic. Madam, suppose I have to see the stereopsis for distance. What will I do? Which test is better? Stereopsis.
Stereopsis for distance.
Yes. I think that was missed out here.
Yes, ma'am.
Yes.
Nice class, madam. Actually, I'm having diplopia after seeing your class. I think I need to come to see you for that. Perhaps you could share me your presentation then sometime. It will be wonderful to go through it.
Yes, sir.
Thank you.
Thank you, sir.
Can we have the next presenter from Arvind Coimbatore, Dr. Anusha?
Next speaker, option क्या?
Shah?
Rest of you, please upload your PPTs. Anusha, you may start, please.
Yes, sir.
Good morning, class. Am I audible? As a budding ophthalmologist, which is that one condition, monoocular condition, which 2 to 3% of the children are suffering from, which is worrying you the most. That is amblyopia for you. Correct, very good. So what are the types of amblyopia? We know that, we already know that. We know that there is anisometropic amblyopia, strabismic amblyopia, vision deprivation amblyopia, and ametropic amblyopia. Since ages, we have been taught that patching the normal eye and allowing the amblyopic or the lazy eye to see is the treatment of choice, but maybe not. Let me give you an example. There are two students in a class. One is a weak student and the other one is a strong student. Imagine in order to help the weak student, you punish the strong student and you continue punishing the stronger student till the weaker student gets better. Do you think this will help the two? Do you think they will be friends after this? Do you think they will coordinate well together? Absolutely not. So punishing the normal eye is not the treatment for amblyopia. See, improving the visual acuity is one concept, but stereopsis, binocularity, clarity of vision are all of paramount importance in day-to-day activities. So there is a shift of treatment of amblyopia from monooptic therapy to dichoptic therapy. So this is the Wiesel and Huber model of amblyopiogenesis. They told that there is neuronal degeneration in the lateral geniculate body and striate cortex on one side, but today we know that amblyopia is a binocular condition where it is structurally intact, but it is monoocularly functionally inactive. And it is our task as a part of the treatment to reawaken these neurons. So dichoptic therapy is the mainstay of treatment now. We give stimulus to both eyes simultaneously, but the stimuli differ in their color, intensity, luminance and contrast. So when both eyes are seeing, the amblyopic eye will see a clearer and a stronger image. This also promotes binocular vision and stereopsis, and very importantly, this also ensures that there is no recurrence of amblyopia and both eyes will continue to work together. So how do we do this? Actually, it is very simple. Children love video games, so use it. So we have many games like Dig Rush, Falling Blocks, which even as adults we love playing, iBit, Occupad, Occutab, Vivid Vision. So where is your equipment? This is your equipment. Look it up in the Play Store. There are multiple games in amblyopia which you can use. Binox is the most commonly used and is very effective in the treatment of amblyopia. Also, you can use these with conventional patching to improve the efficacy of the treatment. Also, monoocular therapies are not completely out of place. Imagine the child wears a spectacle and the glass in front of the better eye becomes opaque every 30 seconds. This works like magic. Imagine there is a sensor in the patch which will detect the exact amount of time the patch is on the eye. So these are the recent advances in the monoocular therapies as well. So there is a small but a significant contribution in pharmacotherapy. Initially, the precursors of dopamine like carbidopa and levodopa were used, but the current wonder drug is citicoline, which is used in many neurological conditions, and it has shown a promising future. So let's not get lazy with the treatment of lazy eye. Let's look for new frontiers in the management of amblyopia, and let's make the future of our kids brighter. Thank you.
Thank you, Anusha. Very interesting presentation, madam. I had one question. This therapy, what you explained, if the patient has an horizontal deviation, will it be helpful?
Actually, we need to correct the strabismus and the deviations, and then we should go for these therapies. That will be more useful.
Post-op only. you mean?
Post-op, ma'am.
Okay.
If there is a foveal fixation on OCT, then after confirming that, if
So
we
that
go
is
for
a
these
prerequisite.
yeah,
Right. So that it was not highlighted here. So
Yes,
I
ma'am.
couldn't understand. Thank you for that clarification.
Any drug other than ceticolin for amblyopia?
So recently, this has been the drug of choice, sir. But before this, there were many drugs, but recently, this is the one which is being used.
Which were the drugs before ceticolin?
Carbidopa, levodopa, dopamine precursors.
Thank you.
Thank you.
With this, we come to the end of round 1.
Nilima, we have a certificate distribution, right? So I would like to invite Dr. Krishna Prasad, Namrata ma'am to the stage.
Uh, a similar event happened in Kochi, and there were very enthusiastic participants who actually made it to the top. So, if they are here, they can receive their certificate of participation as well as the certification of prize and appreciation from AOS on this podium. So, do we have Dr. Neelambika from Maharashtra? Okay. We have Dr. Ankita,
If they can carry on there.
Dr. Prapti.
If there's somebody on from the same place, you can please take
You are
on their
Ankita,
behalf.
kya?
Come,
कोई तो
Pooja,
खड़ा
Yeah,
come.
yeah, yeah.
Pooja.
And Dr. Abha and Dr. Hitish also to be ready. She is taking in the name of Prapti. Maharashtra. Oh, yes, yes, no problem. Fine. Namrata, keep it to Pooja. What a great occasion. Come.
Pooja, it's always a pleasure.
Abha and Hitisha. So the girls are here.
Abha Gupta. Dr. Prapti. We'll be starting the second round of Teachers of Tomorrow. Can we have the next presenter, Dr. Shubhav?
May I start? In the first series of lectures for this early morning, we had droopy lids, and now we have moved on to opening these lids. And from a traditional blackboard teaching, we have always moved to a more white screens. And in this era of black and white, when we add on to a few colors, what if it is bloodshot like this? What do you see and what do you learn from this picture whenever a patient of this sort walks into your clinic? What are we possibly thinking? Are we thinking in terms of the most common cause of prominence of the eye, that is a thyroid eye disease? Are we thinking non-specific orbital inflammation, a possible AV malformation, or something deep in the brain? So let us now look at the most common cause, which is thyroid eye disease. Thyroid associated orbitopathy, let us just remember this image which deals with fat and muscle, and let us just remember this tricycling chart. Now, thyroid associated orbitopathy to start with is a progressive disease. It is a pathology which is centered around the orbital fibroblasts and has waxing and waning courses, and in active stages the mainstay of treatment is always steroids. And to understand this better, it passes through a few phases which we term as the natural history of this disease, and this was particularly mentioned to us by Felix Rundle. What is more important for us to learn from this is that each patient, as he progresses through the disease, has his own Rundle's curve fit to him. Now, it is an interplay between fat, the muscles, and the connective tissues of the orbit. What do we look practically when a patient walks into the clinic? Are all proptosis related to thyroid? Are there any telltale signs? Yes. The one is in the left eye, in this patient, you notice a upper lid retraction. Second is a lid lag and down gaze. Third, a lid erythema. Fourth, conjunctival congestion, more concerned and cornered around the recti, and a caruncular congestion and edema. Putting all this together, we term this as the clinical activity score, and we name it after the first 7 points on the first visit or the baseline evaluation, and whenever the patient follows up with us, the lower three add on to it to making it a total score of 10. Based on this clinical activity score, we have a protocol-based approach in a case of an active TED when the clinical activity score is more than 3, and this involves use of intravenous methylprednisolone in a pulsed manner. By pulse, the first involves the loading dose where 500 milligrams of this IVMP is given on 3 consecutive days, followed by similar pulses in 3 weekly intervals with or without addition of an immunomodulation from about the 4th pulse depending on the clinical response. Moving on, following the administration, you can see that there is a mean reduction in the exophthalmos. These are real life examples. Now, second is a remission in the disease activity with intravenous methylprednisolone and the oral immunomodulation with azathioprine. And third is a baseline reduction in activity, which is very significant in a protocol-based approach over a long follow-up period. After conclusion of the active thyroid eye disease, the sequelae can be a motility deficit and improvement in diplopia with treatment. What if he presents to you this? The answer to this is surgery, and in this we deal with 3 things: lacrimal keyhole, the sphenoid door jamb, and the inferior basin. Thank you.
Thank you, Shubham. It's very difficult to cover thyroid ophthalmopathy in 4 minutes, but you did great. Any questions?
Nice, doctor. It was very nice, and it was like a snippet of thyroid eye disease in a very short time. Yeah, there'll be a lot of things to talk about. Maybe we can have a discussion on that later on.
Yes, sure, very well.
You got any doubt or you are just yawning? Red? You have something to ask? Yes, please.
Yeah, I think the question pertains to what if a patient has steroid-induced glaucoma. Did I hear it right? Yeah. So steroid-induced glaucoma is more so with topical steroid therapy and less with intravenous methylprednisolone. And second is the idea here is to address the thyroid-associated orbitopathy, which we know that it is an autoimmune condition, right? So when we give it in a pulsed manner and not load the body with steroids, we always think in terms of if I were to give you an analogy on this, think in terms of chemotherapy. When we have inflammation, then we have active circulating T lymphocytes in the circulation, right? So it takes about roughly 3 weeks for these population to come again into the circulation from their base. So we are addressing this 3 weekly based pulse therapy based on the chemotherapy model. Just an analogy.
And doctor, I just want to know, I heard something about a visa,
Yes.
like getting a visa to US or something.
Yes. So clinical activity score has a modified version of it, which is called as a visa scoring. It addresses vision, inflammation, and strabismus, and it is used. It is tedious, but commonly we follow the clinical activity score.
One last question. Your patient has strabismus. How soon or how late can you operate this?
Okay. Depends on which phase of thyroid orbitopathy the patient has presented to us. If I would say the patient is presenting to us with active thyroid eye disease, treat the activity first. Address with intravenous methylprednisolone, not to address the strabismus right away. Second is almost a 6 month to 1 year wait period from the remission of activity is when we surgically intervene, because any form of surgery, be it ocular surface, ocular motility wise, or thyroid decompression, it still has a chance of reactivation of this disease. So we wait for 6 months to 1 year from the remission of activity, and there is a sequence we follow. First is ocular motility. We address the ocular motility restriction by strabismus surgery. First is thyroid orbitopathy. We address it by thyroid decompression. Second is the extraocular muscle surgery, and last is the lid.
My
Your
patient
doubt is clear, क्या student? जो पूछ रहे थे?
steroids.
Steroid-induced glaucoma.
You got your answer? No, you have to answer him properly.
Okay. Steroid-induced glaucoma is like more so with topical steroids and not with intravenous methylprednisolone. Any contraindications to steroids is what you meant to ask. Okay.
If steroid cannot be given, what is the alternative? That's the question.
Yes. See, the immunomodulators are a very good option. We use azathioprine and mycophenolate mofetil, but mycophenolate mofetil has a larger safety profile as compared to azathioprine.
It's okay. You just name the drug.
Okay, and then second is there's another newer modality which is called teprotumumab, which is a monoclonal antibody which works on insulin-like growth factor 1. It's work against those receptors, and they have shown a significant reduction in proptosis with use of teprotumumab, which has a relatively safety profile, but still has side effects of hearing deficit with it as well.
You are satisfied now?
What if the patient is from a lower socioeconomic strata?
You should meet him after the class.
Yeah, actually, it's a big long topic of glaucoma and thyroid. It goes on. You can have a seminar on that. I think we should have a different class on that. Actually.
Sure. Thank you. Pleasure.
Next presenter is from the team Towards Tomorrow, Dr. Shebsan. God's Own Warriors, Dr. Hiba.
So good morning, students. Now, let's all imagine that we are in the pediatric ophthalm OPD, right? And our first patient is already waiting for us. Let's see who is it. It's our baby, 1 month old baby. He has a white spot only in his right eye. Now, can you tell me, you all will be having some multiple differential diagnoses in your mind right now, right? But I will ask all of that after this class. Now, so I asked the mother all her family history, if there was someone else like this, any steroid usage, any history of trauma. Then I did multiple evaluation. I did the clinical evaluation. I checked out the fixation behavior. I did a detailed posterior segment evaluation. After all this, I have reached into a diagnosis that this is a case of a monocular congenital cataract. So in this class, I am going to teach you on how to manage this monocular congenital cataract. So grab your books. We're going to discuss under these 4 headings, all right? So first, the timing of surgery. Now, just basic common sense question. It's a cataract, right? So what will be the treatment? It is the removal of this cataractous lens. That much we know. But why are we talking about the timing of surgery in a unilateral cataract? You should always remember, guys, in the last class I taught you that if there is a sensory deprivation, it will always lead to an underdevelopment of the visual pathway. So for that, the timing is very important in this case. So over here, what we're doing is, in a case of a unilateral cataract, we do an early operation. That is, we operate within the first 6 weeks of life. Why so? We have to prevent this sensory deprivation, amblyopia. Now next, usually what do we do after in a cataract surgery? We remove the cataractous lens, we implant the IOL, right? But over here, you just have to imagine, we are implanting the IOL in the baby. The light rays are falling on the retina of the baby. Now what happens when the child grows? The light rays will fall in front of the retina, causing a myopic shift. So that's how it started, or the whole debate on whether to leave the baby aphakic or whether to implant the IOL. So finally, we have reached into a conclusion under the infant aphakia treatment study that it is always better to leave the baby aphakic if the baby is less than 7 months of age. Why so? Because there were so many related complications when you are implanting an intraocular lens. Now I'll tell about the surgical technique. So if you're planning to leave the baby aphakic, you can do a lensectomy with vitrectomy, either through a pars plana route or through a limbal route. Now, imagine you're thinking of implanting an IOL. So first we do a lens aspiration. Why aspiration and not emulsification? Common sense. It's a pediatric cataract. The nucleus is very soft. So we just do a lens aspiration like this using the phaco probe. Now, next that what you're doing is primary posterior capsulorhexis. Why a posterior capsulorhexis? All of us know about anterior capsulorhexis. Why posterior? Because there's a 100% chance of formation of a posterior capsular opacification. And just imagine you're holding a little baby and doing a post-op yak cap. All of that is not going to happen. So for that, we always do a posterior capsulorhexis using cohesive OVD coverage. And then what do? We do an anterior vitrectomy followed by the foldable IOL implantation. Now guys, in the case of an adult cataract surgery, you do the cataract surgery, the chapter is closed, right? But what about the pediatric cataract? Here, after doing the surgery starts the main treatment. The real treatment is starting after the surgery, because you should always remember, one eye was good and the other eye was having cataract. So what will happen? You're operating this eye, and if you're not doing any appropriate correction using glasses or contact lens, you'll end up in sensory deprivation amblyopia again. So we have to avoid that. Also, you should do this proper amblyopia management, that is occlusion of the good eye. And also we should do a lifelong intraocular pressure assessment. So to summarize guys, let's think about our imaginary baby Aryan. What about him? He was a 1-month-old baby and he had a unilateral cataract and which was visually significant. So we are planning for a cataract surgery. Now, when do we operate? I told you this is a unilateral case. So we have to prevent that amblyopia. So we should do an early surgery at 6 to 8 weeks of age. Now, do we place an IOL? No, we do not place an IOL. Now, are you placing an IOL? Can we place it? Yes, after 6 months of age, we can place an IOL. So today's class is done. So in the next class, I will teach you on how to calculate, the IOL power before doing the cataract surgery. Thank you.
Thank you. Teacher, I'm still not clear when to put IOL and when to leave aphakic. When to put IOL and when to leave the child aphakic. I'm still not clear.
Okay.
Could you please elaborate?
Yeah. So why the whole debate started? That you understood? Because
yes.
Yeah, we are now imagining that you're putting an IOL into the baby. Now the light ray will fall on the baby's retina for now. But when the baby grows, what will happen? the
That's
eyeball
fine.
also goes.
What is the age cutoff?
Yeah, the age cutoff is 7 months. If the baby is less than 7 months, we'll prefer to do a aphakic treatment rather than an foldable IOL implantation. But right now, actually, there are so many, better strategies that we can use. We can implant multifocal IOL, three-piece IOL, all of them can be done. We do it, but still, we prefer to leave it aphakic.
So we don't do multifocal IOL in pediatric patient.
Yeah,
Are
because
you sure?
because for them, what we're trying to say is instead of
You
making
mean to multi-piece, I guess.
yeah, multi
You said multifocal. It's not multifocal, multi-piece, I think.
multi-piece, sorry,
Yeah.
multi-piece IOL. Yeah.
It's a three-piece IOL.
Yeah, three-piece IOL.
But IATS is about unilateral aphakic.
Yes, yes,
Right?
yes.
So suppose somebody is bilateral cataract and age is 10 months, axial length is 16. Would you put an IOL?
Okay, so bilateral cataract. For bilateral cataract, when do we do surgery? If it is visually significant. So the same reason as above
So it's
to
not about
prevent the
surgery. I'm
amblyopia.
asking about IOL. Bilateral cataract,
Yeah.
10-month-old, axial length is 16.
Yeah, we can place an IOL, but the only difference is you have to use a different SRK formula. That is the IOL calculation formula. We have to use an SRK2 formula.
So axial length 16, will you put an IOL? Are you sure? So the point, okay, now I'm not a student, I'm just telling you this. So when you are putting an IOL, you have to take into consideration the axial length, the white-to-white diameter, and age.
Yes.
Unilateral, most likely you have to put an IOL, that's the risk of amblyopia is there. But bilateral, if axial length is 16, less than 17, you can always wait, because amblyopia won't be a risk factor for that. Thank you.
Thank you, Hiba. You made me understand the management of unilateral cataract. Thank you.
Next presenter is from team Towards Tomorrow, Dr. Shebzan.
Hello, hello, hello. Am I audible?
Yes, 1 minute.
Okay.
Shivan Mama.
You can come here. So we have a prop here. You can start.
Just a minute, sir.
We'll go forward to this page.
Yes, sir, कुछ चाहिए. Yes, please.
Good morning. How's the energy levels in the morning? Everybody, I can't hear you. Good. So myself, Dr. Shebzan Mohammed, and today I'll be teaching a topic on DMEK and PDEK. So what is DMEK and what is PDEK? DMEK, here I have the layers of the cornea, epithelium, Bauman's membrane, stroma, Duas layer, Descemet's membrane, and the endothelium. DMEK, or Descemet's membrane endothelial keratoplasty, is a condition in which the Descemet's membrane and the endothelium of the host is replaced by the Descemet's membrane and the endothelium of a donor corneal tissue. In case of PDEK, pre-Descemet's membrane endothelial keratoplasty, the same thing is done except for the fact that the Duas layer is also replaced by a donor corneal tissue. Now, why is this being done? It has been shown that in thinner grafts for lamellar transplants, there is a faster graft clearance, a reduced rate of rejection, and an improved visual outcome. For who is it done? Mainly for pseudophakic or aphakic bullous keratopathy, Fuchs endothelial dystrophy, endothelial failure in primary penetrating keratoplasties, other endothelial dystrophies, and iridocorneal endothelial syndrome. How is it done? Most important step, donor preparation, recipient preparation, and graft placement. Now personally, I believe that a surgical topic cannot be taught theoretically. So let's go on with the surgery and let's do the surgery together. So here, basically, I have an endothelium of the cornea. Can I have the volume please a bit? Now, a small amount of balanced salt solution is given. The peripheral Descemet membrane is scored with the help of a Sinskey hook, and this is basically done for the entire 360 degrees as shown in the video. Now, the small peripheral tags are removed. And after this, what we do is that we do a further staining with the vision blue so that we can have a better visualization. Now, the scored peripheral edge of the Descemet membrane is again redefined, and then the freed edge is held with the forceps, and then it is peeled. Now, once it is peeled to the center, it is again repositioned, and then we do a partial trephination to the desired diameter with respect to that of the recipient. Now, the peripheral rim of the descemes membrane is removed, and then the descemes membrane is held at the trephined edge, and then it is peeled off. Now, once you are done with that, let's come to the recipient. A superior section is done, a tunnel incision is made, a cornea is marked, and in this case, it is about 8.5 millimeters. Side port incisions are made, then the side ports are done, and finally, a small amount of air is given to the anterior chamber. Very important step, students. Listen over here. We do a descemetorexis with a reverse Sinskey hook, not a normal Sinskey. And then the section is opened with a keratome. The peeled descemes membrane is again further peeled towards the center, brought out of the eye, and finally, completeness is assessed with comparing with that of the surrounding markings. Now, the graft made earlier is inserted using a Guider Dimec glass injector, and then a suture is given, and finally, gentle tapping movements are done to center the graft, and finally, an air is given for a tamponating effect. Now, can you tell me one step that the surgeon missed? Yes, he basically forgot to make a stromal window so that we can make an asymmetric alphabetic impression, so that we can identify that the descendants goes towards the superior side, and the remaining part goes towards the inferior side during the surgery. Now, what are the complications? Intraoperatively, we can have a donor tissue damage, scarring due to retained descemes membrane, ejection of tissue through tunnel, poor visualization, and upside down flip of the graft. And postoperatively, most commonly, we can have a pupillary block glaucoma, a graft dislocation, and a primary graft failure more than graft rejection. So this is one non-stop table for all what I've explained before. Please, please, please revise. That's the only way how you'll score in the exam. Thank you.
Thank you. What was that prop for? I think you didn't utilize your prop.
I've just mentioned the layers of the cornea, sir. For the students who are like just new to the ophthalmology, so they can idea of the.
No, I'm saying you didn't utilize him.
No, sir, I told the layers of the
He
cornea.
was just standing like that. Okay. So given a choice, what would be your preference, PDEC or DMEC?
Sir, DMEC, because it is more widely used and people have much more exposure, and it is actually the ability to take the graft is like much easier as compared to that of the PDEC. So, and the thing is that since it is a much smaller graft, so there is a lesser rate of rejection and faster visual outcomes as compared to that of a PDEC. So I would suggest I would still go for a DMEC.
No, it's a much lesser graft. What does that mean?
A much lesser graft in the sense that, see, the thing is that we have the DSEC, then we have the PDEC, and then we have the DMEC. So in the pre-descemes membrane endothelial keratoplasty, an additional layer of the cornea is taken, but in the DMEC, we only take the descemes membrane and the endothelium.
So it's a less stromal
Yeah,
tissue,
that's what,
not
that's, yes, sir.
it's a much lesser graft.
Okay,
It's a stromal antigenic load is not
Less.
there
Yes, sir. That's
in
what
DMEC compared to PDEC.
Yes,
Okay,
sir.
thank you.
Next day, suppose, sir, you find that the graft is free floating. What will you do? You open the pad and you see that.
The graft is free floating.
Huh?
If the graft is free floating, ma'am, suppose there is an upside down twist or there is a mild dislocation, I would suggest that we take it to the OT and we try to maintain the air. It is because there is not proper air tamponade, the graft is free floating here and there. So I would suggest like we can just take the patient to the OT the same day, give a small amount of air, and then the graft just
How will
gets
you
attached.
identify which side is up and which side is down?
Yes, ma'am. That was
That
a
is
miss.
initially primary thing. You had a staining.
Yes, ma'am.
Free floating.
Ma'am, I'll refer to it and let you know.
Okay, thank you.
Free floating, if mark is still visible, you can always put an air bubble and replace it. If mark is not visible, then please take it out, do a fresh graft.
Thank you, sir.
Next presenter is from the team Diamond Dazzlers,
Neelima, where are you?
Devi Kartia.
Slide change. Slide changer, please. Thank you.
Dr. Anu, please introduce the next speaker. Please start.
Good morning, students. Today you are all students in ophthalmology. Tomorrow you are going to be consultants. Well, here comes your first patient. She has been to so many hospitals. Meet Mrs. Vimala. None of the doctors are interested in doing her cataract surgery, saying she has got some problem in her retina. Now, if you want to do her cataract surgery, how are you going to guarantee your vision? Do not panic. Your guiding angel has come with help with macular function test. Now, the 5.5 millimeter area in the macula in the posterior pole with the highest density of cones, tall RPE cells and the xanthophyll pigments, there lies your answer. Macular function test can be divided into psychophysical on one side, electrophysical on the other, and a very confused poor student in the middle. Do not worry, I am here to help you out. Let's go back to the story of Vimala. She had distortion of vision and defective vision. She had nuclear sclerosis of grade 2 and her fundus was looking something like this. She's a terrific cook, by the way, so much so that when it's time for her aloo, paneer and chutney, the meal gets fully over. Now, this will help you to remember the macular function test for a clear media. These are the macular function tests for clear media. Remember, when you test the visual acuity gets worsened with pinhole in case of macular disease. Now, coming to the photo stress test. Now, in this test, the macula is bleached with bright light and the poor visual pigments are bleached and they take time to regenerate, normal time being 15 to 30 seconds, and this can help to assess the macular function. The 2-point discrimination test can be easily remembered with the rule of 2s. Now, microperimetry combines perimetry as well as retinal imaging and it helps to accurately assess the specific retinal location. Here comes Kuttappan, husband of Vimala, raising his fist saying he wants to get his cataract surgery done first. Look at his eyes, he has bilateral mature cataract. But just look at my lazy interns over there, they prefer eating even over viewing patient's eyes. Now this sentence is going to help you remember macular function test for a hazy media. Maddox rod, when it kept in front of the testing eye, will produce a straight line in case of normal eye and discontinuity will be present in case of a macular disease. And at potential acuity meter and laser interferometry, potential acuity meter will project a Snellen's chart and laser interferometry will project a fringe image into the dilated pupil. These strange shapes are the entopic phenomenon, another macular function test. Then you have got the electrophysiological objective test, your electroretinogram, visual evoked potential VEPs. There are recent developments happening incorporating critical flicker frequency and artificial intelligence into the macular function assessment. Now you know the names. I just want you to introduce the names of the macular function test for a clear and a hazy media. Any guesses with these 4 clues? What is it? Amsler grid. Yes, very good. Amsler grid. Who knows? Like Mark Amsler, one day one among you in my class will develop a unique macular function test and that goes by your name and I will be so proud as your teacher who taught you macular function test. Now, grab your macular function test, go to post-operative ward. I have just operated Vimala. She is still complaining of metamorphopsia, by the way. It is the bedside test that will help you. Make sure you do it today itself. You can scan this QR code to get my exclusively handwritten notes, but please make sure you read it today itself. Alright? Thank you.
So what was the, we got a little bit confused. What do you mean by macular function test? Is it to assess the visual potential?
Macular function test to assess residual visual potential in case of cataract surgery, in case of dense media, in case of
what is Amsler grid is going to tell you about macular function?
Amsler grid will help us to assess the central 10 degree of fixation in either side of the fixation. So if there is any metamorphopsia or is there any scotoma adjacent to it, there are 7 charts in Amsler grid.
That I know, but I don't know whether the other judges would agree with me or not, but that's not a macular function test that we use for visual potential assessment.
No sir, it is not for visual potential, it is to assess the macular assessment in case
basically
of
not assessment, it's a monitoring.
Yes sir, macular degeneration, ARMD patient, CNVM,
to know
CSCR.
whether it has deteriorated or not, that is what is used.
Yes.
But I doubt it's a macular function test.
Can be used for screening primarily, just basic screening.
Yes.
Thank you.
Yeah, nice presentation, Dr. Devi, and yeah, it's the animations and the analogy was good. Thank you.
Thank you, sir.
Who was that lady with white sari? Was it you? The first slide. Or Ma Saraswati?
I just wanted that everyone remembers I wear or wore this sari so that it will be easy to correlate,
Okay,
and when you
good.
go home it will be easy to remember. That's the whole purpose of the class. Thank you.
Next team is from VMMC Safdarjung. Dr. Nishi.
Hello, am I audible? Yes. Okay. My timer is on. Safdarjung, ma'am. VMMC Safdarjung. So, a very good morning, everyone. And I know it's very difficult to pay attention in the morning. This is a topic you don't want to miss out on. Traumatic hyphema. Okay. It's an important short note as well, so take pictures when you need to, okay? Let's look at the basics first. What is hyphema? Blood in the anterior chamber is called hyphema. When it's due to trauma, it can be due to a penetrating injury, direct damage to the blood vessels, or it can be due to blunt injury, shearing forces to the blood vessels. Okay. How can we make grading of this easier? Grade 0 is microhyphema, where we see circulating blood vessels. Excuse me, just my slides are just running forward. Grade 0 is microhyphema, where there are just circulating RBCs. Ma'am, can I just pause for 1
These are
second?
practical problems a teacher can encounter.
Okay, I'll just proceed like this. Grade 0 is microhyphema, where there are circulating RBCs in the anterior chamber. Grade 4, the opposite end of the spectrum, is where there's a total ball hyphema. It means that the anterior chamber is completely filled with blood. Okay, it's also called 8-ball hyphema. Can anybody tell me why? Dr. Ritu? If you can't guess, it's because the deoxygenated blood appears blackish in color, and that is how an 8-ball looks if anyone plays pool over here. The grades in between are 1, 2, and 3, where we see the level of the blood in the anterior chamber. Grade 1, less than 1/3 of the anterior chamber volume. Grade 3, more than half of the anterior chamber volume. In between, we have grade 2. All right. How do we clinically proceed with these patients? History is extremely important, and we must not forget that there are medical legal aspects to this. A history of any intraocular implantation is very necessary to take, and sickle cell disease is something very important that we have to notice. Okay, after a quick initial examination, we rule out any open globe injury. We go through a thorough ocular examination. Of course, visual acuity and IOP measurement is extremely necessary. Another homework for you are what are the seven rings of ocular trauma, blunt ocular trauma. I have to ensure that I don't miss out on RAPD, any adnexal or lenticular or posterior segment findings. Yes. If I can't see anything very clearly, I'll prefer an investigation. I can do an anterior segment OCT. Here we can see some blood in the anterior chamber over here, a UBM, and a posterior segment B scan. Here I can see vitreous hemorrhage as well as retinal detachment. Yes. Not to forget, we'll have to do a CT scan to look out for any orbital fractures here. So there's blood in the anterior chamber. How does that affect the complications here? It can stain the endothelium, and if that occurs in a child, it can lead to amblyopia. It can cause synechiae, and it can cause a rebleed, which is a huge burden for us to manage. The IOP rise can be due to inflammation or a pupillary block. And if this IOP is raised for more than 50 mmHg for 5 days, 35 mmHg for 7 days, and in sickle cell disease, actually any IOP, it can lead to optic atrophy. It's something that we dread. So we'll have to manage it as an ocular emergency, and integrated management is needed. So conservative management when there are no other associated injuries, topical NSAIDs, topical cycloplegia, topical steroids, anti-glaucoma medications, Just remember, carbonic anhydrase inhibitors are contraindicated in sickle cell disease. And the IOP, best corrected visual acuity, will have to be monitored in follow-up. Dr. Ritu, my favorite student again, can you tell me what this is? Yes, angle recession. A gonioscopy will have to be performed later on to see other complications. So when do we surgically intervene? When the IOP is not controlled, when there's endothelial staining, if there's any amblyopia that might occur, and synechiae formation. So surgical methods, we can do a paracentesis, we can express the clot through a corneal incision, we can do a bimanual irrigation aspiration, and you can even use the vitrectomy cutter. Thank you, and I'm so sorry for the technical problems here.
I have a small doubt. I mean, I've been playing pool since dog years now. I still didn't understand why you say it's an 8-ball hyphena.
So there are two things here. One, that its color is darkish. The deoxygenated blood in the anterior chamber appears dark like an 8-ball. There's another thing. The shape 8 is important here. The clot here can be a bilobe shape, which causes a pupillary obstruction as well.
Why does it become 8 like an hourglass or something?
Because of the pupillary margins.
Okay.
I will see my students are much more intelligent than I am. I'll have to go and read up again.
I think I got to go to the pool again and play some more.
Can you tell something about corneal staining?
Corneal staining, ma'am.
Which is seen in cases.
So in these cases, again, I mentioned about IOP again and again. So corneal staining occurs when the endothelium is stained with these hemosiderin droplets or because of the blood. Now this can happen when the IOP is raised. So like I said, more than 60 mmHg for 2 days, I'll have to take up this patient. Again, 50 mmHg for 4 days, more than 4 days, and 35 mmHg for 7 days. I'll have to take up this patient.
Ma'am wanted to convey to you is that irrespective of the IOP, if you see blood staining is happening, please go and drain
I
it.
will have to do it, especially for the pediatric population to avoid amblyopia. Thank you so much.
Nilima, where are you?
I'm right here. Next presenter is from team Gujarat, PJ Medical College, Dr. Sania.
Sania Gulwani. हाँ सर आ जाओ नहीं सर Good morning, learners. My name is Dr. Sania Gulwani. What a good morning, right? So, I'll start with a fun fact. So, the photographic memory is one of the most retained memory in a human being. Keeping that in mind, I'll start my presentation on posterior vitreous detachment. As the picture depicts, it's the detachment of the posterior part of the vitreous from the internal limiting membrane of the retina, from where it is attached. It is attached at the points of ora serrata, blood vessels, fovea, and disc margin. So, what is the pathogenesis? It is basically disruption of its natural environment, that is syneresis, liquefaction, synchiasis where it is condensed, this incomplete PVD where the part of the vitreous is still attached to the retina, and incomplete PVD where it is completely detached. Why do you all look so confused? Let me make your concept more clear. We all know what jelly is. It is like vitreous having gel-like consistency. It does not fall off. But when there is condensation and liquefaction, there is detachment of the vitreous from the base. Hence proven my point. Next is risk factors, guys. Keep in mind photographic memory. So there's old age, there's myopes, there is trauma, there's post-laser, post-surgical procedures, and there's post-uveitis. What are the silent clinical features? Sometimes patient doesn't have any problem and it's fine. But sometimes he complains of floaters. Floaters is basically presented as black or gray dots, lines, ring shapes, thread lines, and spider shape. And last, flashes. So why does flashes occurs? Just like the Spider-Man, there's a part of the vitreous which is attached to the retina. It pulls the retina in causing lightning effect. So what is anomalous vitreous detachment? As the name suggests, it is abnormal vitreous detachment, means the liquefaction is more than the vitreoretinal dehiscence. So it causes vitreoschisis.
Imagine this as a vitreous. There's separation of a layer of vitreous from another. Hence, this part becomes hypercellular and gets other to the underlying structure, which if causes centripetal force, can lead to macular pucker, but if causes tangential centrifugal, it can lead to macular hole. Partial PVD is part of the vitreous is still attached. So, when there is vertical traction, it can lead to alteration of the contour of its underlying structure, which could be either fovea or pupillary. It can lead to vitreomacular traction, secondary macular hole, or vitreopapillary traction. And if it's peripheral, it can lead to retinal detachment. So what are the complications? As already suggests, traction, it can lead to retinal tear. If it is attached to the peripheral lattice degeneration, it might not have any problem and it can lead to operculated tear. But if there is a crossing of the blood vessel, it can lead to rupture of the vessel, hence leading to vitreous hemorrhage. So how will you diagnose this? Dilated slit lamp examination will show collapsed posterior vitreous in the anterior vitreous phase. This is the optic coherence tomography showing the presence of hyperdeflecting membrane in complete PVD converting into the complete PVD. Then there is the ultrasonography. Here most of the beginners will say, this is a posterior vitreous detachment, ma'am. But no, we need to have an optic nerve head section to give a diagnosis. Now this is justified, this is retinal detachment. This video might prove my point. This is a hyperechoate posterior vitreous membrane, and it is a kinetic sonography which shows the movement of the vitreous with the movement of the head. And this will show that there is a presence of vitreous which is not attached to the optic nerve head. What is the treatment? If the patient is happy, it's a coronary condition, don't give any treatment, patient will adapt. If the patient is suffering because of the floaters and the flashes, we can go for chemical or mechanical vitrectomy. Chemical vitrectomy being occluroplastin, which is enzymatic action, which converts incomplete PVD to complete PVD. Next is acute. If the patient have no other complication, just acute PVD, follow up every 2 to 4 weeks for retinal examination. If there is vitreous hemorrhage, we can go for bed rest, head neck elevation, and the vitreous, when the hemorrhage subsides, we can go for retinopexy. If there is PVD with tears and operculated, as discussed, no treatment is needed. If the symptomatic, immediate treatment is treatment. These are my references. Thank you so much, class.
Thank you. Where is your assistant? What was he supposed to show us?
The vitreous, he had a jelly in his hand, which has a consistency like vitreous. Vitreous is like a gel-like structure.
Yeah, but
okay.
This prop was not used.
Sorry.
The other thing was good.
Yeah.
With the tissue paper.
Can I demonstrate?
And what was that?
I'll show it again. So, man, this is a vitreous, which is like a gel-like structure. It does not comes off because it attached to the base. Whereas there was a condenser liquid vitreous, which was not in its proper environment, which was not getting. So when I did it, the maneuver, it got detached from its base.
He missed it.
No, he did.
But you should have taken a small break to say yes, his demonstration.
Yeah, sorry,
You
sorry.
would not have missed it. Thank you.
Sorry, ma'am.
Yeah, nice, very nice, and nice way to show it, especially with the tissue paper, because that actually shows you the so-called traction and the holes happening. Nice, thank you, interesting.
Thank you.
Next presenter is from Team AIMS Nagpur, Dr. Samarpita Dhar.
Suprabhat Kolkata. I'm sure you all are very tired by now. So today, let's play a game of Quidditch so that all your fatigue goes away. Now imagine if we couldn't correct the myopia of Harry Potter. This is how Voldemort would look to him. So could he defeat him? No. That is why safeguarding of vision in pathological myopia is extremely important. So, what is myopia? Myopia is when the parallel rays of light coming from infinity are focused in front of retina with accommodation at rest. So, can someone here tell me what is the normal axial length of the eye? Correct. It is about 24 mm. So, when the axial length is more than 26.5 mm and when the spherical equivalent is more than 6 diopters, we call it high myopia. And when there is a high myopia with structural degenerative changes in the posterior segment and functional loss of BCVA in contrast, then we call it pathological myopia. So what happens in pathological myopia is there is a progressive elongation of the axial length leading to degeneration of all the layers of the retina, and choroid and vitreous, that is from inside to outside. So there is a tessellated fundus appearance, chorioretinal atrophy, RP Brooke membrane cracks, coin-shaped hemorrhages, Fuchs spots, and posterior staphyloma, and even myopic neovascular membrane. So now that Harry's vision has been affected, how can we save it? First, we will give him what? Yes, spectacles, which is monofocal, bifocal, and multifocal, that is progressive. Similarly, on the surface of cornea, we will give him an orthocale lenses, which remodel the shape of the cornea, thus causing a curvatural hypermetropia, which has an advantage of decreasing prismatic aberration, but has a disadvantage of poor patient compliance. Similarly, soft contact lenses are used in children of 8 to 12 years of age. Also, cornea-based procedures like PRK, LASIK, and intrastromal procedures like LASIK can be performed and lens-based procedures include refractive lens exchange and very important surgery, phakic IOL, in which myopia of 3 to 20 diopters is corrected and requires a preliminary anterior chamber depth of at least 3 mm. So, when the peripheral rays of light coming onto the peripheral retina are focused behind it, the eye adapts by elongating it, which is the concept of hyperopic defocus, which is prevented in bifocal and progressive additional lenses. Similarly, now that we have managed, how can we prevent its progression? So, if Harry Potter stayed on his pensieve all day, and how could he have won the match of Quidditch? That is why we asked our children to play outdoor games like Quidditch or present day basketball, etc., and limit their indoor work like looking at the pensieve and even mobile phones. So, how to prevent it pharmacologically? We give 0.01% atropine, pyrazine, both of which are based on inhibiting the axial growth, and also methylxanthine. So now that we have prevented it, if complications develop, how can we manage it? First, if there is a lattice without retinal hole, we laser it. If retinal hole is without retinal detachment, we still laser it. And if a rhegmatogenous RD has developed, then we operate it by pars plana vitrectomy or macular buckle. And if any maculopathy has occurred, then we perform pars plana vitrectomy. And if choroidal neovascular membrane has developed, then we give intravitreal anti-VEGF. So now we come on to what we will do if there is a progressive and irreversible loss of vision. We give them LVA for distance, telescopic system, and for near magnifiers. So congratulations, Harry has snatched his snitch back, and so his vision is in his hands. Thank you.
Thank you, madam. While showing the ICL things, you said that it can be put in -3 myopia. So does pathological myopia have -3 refraction?
That is a very good question. That means you are paying attention to my class.
Very attentive.
Yes.
Is there any role of laser? Answer
yes,
that.
sir.
Please go ahead.
ICLs are usually preferred when there is a high refractive error, but if we quantify, so it can be used in even -3 to -20 diopters of myopia.
That is the general indication. In pathological myopia,
In pathological myopia, we will prefer to give because we want to prevent the progression.
progression is important, or what is the surgical complication that can occur? Any complication?
That is a good question. That means I have to read up so that I can
No, you
be
need
better
not to
than my
read up.
students next
The
time.
simple point that ma'am wants to make you is pathological myopia. There may be some retinal changes, right?
Yes.
So planning ICL in such patient may not be ideal. You know, the right answer would have been first you have to screen the retina, any tear, anything is there, any degeneration you have to laser that. Then you can go ahead with ICL or phakic. Thank you.
Thank you.
Here we come to the last team, Team Arvind Coimbatore, Dr. Ruhail.
Check. Am I audible? Can I start?
Yes, sir.
I'm sure you're all very tired and angry and hungry at this moment, but trust me, this will be a breeze. So, you can start. So, I want to talk to you about a condition that I saw in my patient the other day. His name is Preetham. So he was in the bar the other night, he's a bartender, and he got into a fight and he got smashed in the face by this glass. He then presented to me with the above symptoms and signs. He said his eye appeared smaller and he had significant doubling of vision. What do you think it is? Devu, what is it? Yes, it's an orbital floor fracture, and I'm going to teach you about orbital blowout fractures. Now, orbital blowout fractures can be defined as a fracture of any of the walls of the orbit and not necessarily just the floor as I used to think before. Now, there are many theories regarding the same. Preetham was smashed by an object larger than the size of the aperture of the globe, and therefore there was a rise in intraocular pressure, and therefore led to a buckling of the underlying inferior orbital wall. This is known as the hydraulic theory. In either of the theories, the hydraulic or the buckling theory, you will have a prolapse of fat and contents into the adjacent sinuses. Now I'm going to ask you a series of questions and you're going to tell me what the exact clinical features are. Suppose there was edema and fluid extravasation into the skin. What do you occur? Yes, you would have ecchymosis. And are there conditions where there is no ecchymosis and periorbital edema but still a fracture? Beat up. White-eyed fractures, very important, never to miss. What if there are muscle entrapment within the fracture? What will happen? Yes, you have limitation of ocular mobility, and it can be seen in this child, which is very common in children. It's called a trapdoor fracture, and this is because of the elasticity of the bone. What if there's fat prolapse through the fracture? You'll have an ophthalmos, as seen in this child in the left eye. And what if the fracture extends all the way up to the sinus? What did you see? Emphysema, crepitus, wonderful. And what if the infraorbital nerve is involved? Infraorbital anesthesia, which is a very, very important condition and sign to pick up in cases where there are no external signs of injury. There are main three reasons to operate, and I want you to remember: significant entrapment, an ophthalmos greater than 2 mm, and a large fracture greater than half the size of the floor. Now, a force reduction test will help you determine if there is significant entrapment, and a Hess charting will help you document the same. But most importantly, you need to do a CT scan to document the size, site, and location of a fracture. Can you tell me where this is? Angita, can you tell me where this fracture is? Yes, it's in the roof. Here, Devu, floor. And here, floor. Wonderful. Treatment, as I've already told you, treatment is mainly observation. Observation in most cases. Very few cases require surgery. But what is the one condition where you must operate immediately? Yes, trapdoor fractures and in children. Most of the conditions, you can take your time. You can wait for 2 weeks. And why? Why do you allow for 2 weeks to wait? You let the edema and hemorrhage settle. And so many times the diplopia might settle after that. And you'll be wrongly operating. Sometimes you might have a late ophthalmos presenting after 2 weeks. You need to catch that. So wait for 2 weeks. Can you tell me what approach this surgery is depicting? It's a transconjunctival approach to a fracture. As you can see, the implant was placed, drilled, and subsequently the fascia and all are closed. There are other approaches as well. There's a transcutaneous approach, and you can have a transantral approach. But in all approaches, you need to use implants. And these implants can be autologous, allogenic, and even alloplastic implants. As I conclude, I want to say orbital blowout fractures are common in our day-to-day scenario, and they have a typical presentation, but you must not miss them, because if you do, you might have significant morbidity to the child, and you will they therefore need prompt treatment. Thank you.
Thank you, Dr. Chako. Yeah, I understand blowout a little bit now. One thing I was wondering, I had a patient very similar to the way he got beaten up, but he got beaten up by two people with 2 bottles on his head, and he came with 2 black eyes. One guy hit one eye, the other eye hit the other eye, because he didn't have any other eye to hit. Had he had a third eye, maybe that also could have been hit. So, and then he became unconscious and fell down, and he got up after some time, and he was just blabbering this bartender, What was I missing? He came with both eyes, blue eyes, and was blabbering, and his friend said he's not talking sense anymore.
He might have an intracranial injury and raised ICT.
I mean, what do I need to do in such a case? I mean, can I handle it, or?
You definitely need a neurosurgical consult, a CT scan, to make sure there are no other injuries inside the brain.
Actually, what I read is that when you get smashed up on the face, there's something called the base of the skull which can actually break up. And when you look at them, they look like a raccoon.
Okay.
And that's how he came to me. So a raccoon eyes, when you see in a blowout fracture, is indicative of a base of skull fracture. And if you're in an ophthalmic setup, please send him out of your OPD as fast as you can to a general setup where you have a neurosurgical department.
Yes, thank you.
Thank you.
Doctor, what is the best implant? As a student, I want to know. You gave a list, entire list. So which is the best one?
Sometimes they use titanium implants right now, which is very friendly towards the body.
Why?
They are not very antigenic and
Cost factor?
they are more expensive than the rest.
Thank you.
Okay, thank you. Meanwhile, you judges can keep the score so that she can tally it. One point, all these patients, those who come with trauma, as the video suggested, MLC, medical legal case registration is very important. So you people should do that. Okay, don't forget of doing that. And one more question to this blowout fracture. I don't know, I'm a cornea surgeon, but during my MD, what I have read is whether to intervene or not, it depends on the presentation also, within 48 hours or after that. Is there something like that?
As I've said, most cases you can wait for 2 weeks to let the edema and hemorrhage settle. But if there is a case where there's a trapdoor fracture, the oculocardiac reflex is involved, you have bradycardia, all of that, the muscle is being stimulated by oculocardiac reflex, then you need to be operating immediately.
Yeah, you're right, Dr. Chako. Actually, we intervene as soon as possible as the edema comes down. It may be 1 week, it may be 3 days, 5 days. So 2 week, there's a 2 window period is what you're talking about, the 2 week window period and the 4 month window period. So we intervene as soon as possible.
Nilima, do you have the list ready? Then please call.
Thank you, audience.
I think Dr. Namta wants us to move on to the next session. So this hour distribution we can do it later, I guess.
Sure. Just
Thank
one word. Fantastic presentation by all of you. I know you made this as a presentation for a conference, for a competition, but it'd be fantastic if you had such presentations for all your students for your life. I mean, ophthalmology would be so interesting if we all had such presentations when we studied all throughout. It makes small topics much more interesting, and it gives you an insight for every student to ask questions. The day a student asks questions to the teacher is the day that you know that the department is maturing and students are actually getting better and science will progress. Thank you.